start dissection now. This session will continue till 12:30. After that, we'll have lunch according to the program. Our way in dealing with the course is to give just a practical lecture. It's not a theoretical lecture. It's just how to do and different techniques, just to highlight it. And then we demonstrate it. After that, in the section by one of our guest faculty. And next to that, we will do it yourself. So we'll start by the first step. We get the anatomy, we get the radiology. Now just we'll go step by step in a little bit more details. So I talk about in 10 minutes about the aspectum and midmeatus antrostomy. And Dr. Sam Mergarani will talk about the middle turbinate and anterior molecule. And those two parts will be the dissection, the demonstration, and your dissection. So unseen process, we know it's a G-shaped process. It's hiding the midmeatus. Can I have a pointer? Yes, pointer. It's hiding the natural ostium. If you don't remove part of it, you will not see the natural ostium. And it's, as it can be seen here, it looks like a G shape. And the amount to be removed is according to the disease, but most of the part is we remove the upper tooth layer. Unless the frontal is involved, you can go up higher and remove the upper tail from the frontal of the unseen process. It's very important to remove, and most probably it can be missed is the inferior part which go horizontally backward. This part usually, when we come here, especially with the beginners, they can lift a small part, and this is very important part for the failure of the drainage in maxillary sinus. So, for sure, we have to understand the different insertion of the unseen process. It can be mostly inserted with the laminar radicia, or it can go up to the skull base and even to the turbinate. It's a more complicated, but it's symbolization. To reach our goal in dealing with this unseen process, we have to look very carefully to the CT scan and to look it in depth to see the different cuts, oral and surgical, looking especially to see the unseen process insertion and relation to the maxillary sinus. For example, if the sinus is wrong, we have to be very careful and pick it up from the CT scan, how the unseen process is very near to the radicia and so forth. We have to look also for the different variations in the unseen process. For example, here we have an aerated unseen process. It's with an air cell, so we have to take care of it. Again, endoscopic and CT scan view can show also the anterior or posterior fontanelle and the Concha Bullosa variation in the middle turbinate. The technique to do is we have different technique, and it depends on the anatomy and the patient, the disease itself, and your preference and experience. Sometimes using the second line, and sometimes using the freer to remove the unseen process, and help also by the forceps through cutting or upiling. And it has to be twisted or through cut also can be used here in medical. I can show here small video. Just show the basic dealing with the surgery. We have to look carefully at the start, especially in the case of nervosis. Where is the answer? We have a lot of things that looks like the answer, especially when we have nervosis. So we have to make a congestion and looking very carefully. For example, here we can see the answer process with the behavioral changes. And then we can deal with it. We have to remove that part of polyps that hide in your view, so we can deal very carefully and to remove the answer process in a very manner. So here you can see that the answer process become more clear. For the part of midmeatus antrostomy, that the natural ostium usually is very rounded, clear, sharp edge, usually, but not always, and it's hidden by the ulcer process. You have to move the ulcer process to look for it, and sometimes it will be mixed up with the anterior or posterior turbinate, so you have to look very carefully. Usually it's higher and it's behind the ulcer process. Leaving part of the ulcer process is one of the important causes of failure in the midmeatus. Drainage. Variation in the middle turbinate is very important to look for to have a good drainage and osteotomy, midmeatus. Presence of anterior fontanelle or posterior fontanelle is very essential part in to deal with during the surgery. We have to communicate those opening through the natural ostium, so we have a good and clear opening, so it will help in the drainage. Thank you.
This is probably my third or fourth year in a row participating and very happily contributing to this course. I'm very thankful for them for having me here again. My talk today will be about the endoscopic anatomy of the middle turbinate and the anterior ethmoid hair cell. And we're just going to go through some tips and some pearls of how to practically accomplish the first session of our dissection today. So it's going to be really at the point practically, and we will apply this right away now, inshallah, in the head of the dissection. So endoscopic anatomy of the middle turbinate and the anterior ethmoid. A few articles that I really would like you to have and review this periodically, as this probably has the most recent nomenclature of what people have agreed on in describing the paranasal sinuses. I work in Makkah, both in the University of Bullosa and in King Abdullah Medical City, and come from there. Something to keep in mind is the principles of FES by Professor Heinz Stambler. Is the principle of FES is to remove as little as possible and to preserve as much as possible, and from this comes the mucosal preservation techniques that we are always talking about. So the middle turbinate, beautifully described by Prof. Rida Kamil, has the anterior buttress, the vertical portion, the lateral attachment ridges, the basal lamina, and then the posterior buttress. We can talk a lot about the management controversy about turbinators versus non-turbinators regarding this issue, but this is kind of an open discussion that we can talk about during the course. So going back into the anatomy, this is a sagittal cut, and when you first look inside the paranasal sinuses, the first thing is you're going to see the anterior part of the middle turbinate. And I pay very much attention when I have somebody operating on the sinuses and me observing. I observe how well they respect the anterior part of this middle turbinate. If I see them banging on it and destroying it and causing it to bleed and not respecting it too much, I know that very soon I'm going to take away the scope and continue the surgery. But if they show much respect to this part, I know that the rest of the surgery will go in very smoothly. So this is kind of an early hint of how the rest of the procedure is going to be, showing respect to the middle turbinate, especially the anterior part. And then we go to the vertical portion, then to the lateral portion, which is the basal lamella. And then we have at the end the posterior portion of the middle turbinate, which is very important to recognize and to respect as well, because from here the sphenopalatine artery will come out, and debriding this area aggressively will cause a lot of bleeding. This is a cadaver dissection picture of the posterior wall of the maxillary sinus, and then after that is the crista ethmoidalis, and behind that comes out the superior sphenopalatine artery. Another sagittal picture with more details about the paranasal anatomy is done by Frederick Cohen, and it's a very useful piece of art that has been published in the paranasal sciences. The concha bullosa is air-filled middle turbinate, pneumatized, can predispose to middle osteonatal complex disease. But it's important to recognize the bulla ethmoidalis from recognize the concha bullosa from the interlamellar cell. So concha bullosa is air filled in the middle turbinate, but if this pneumatization goes up into the anterior part of the middle turbinate up to the skull base, this is called an interlamellar cell, and we'll show you an example of it. So just by a nasal endoscopic view, you should be able to realize that this is a concha bullosa and there's air inside the turbinate, even without doing a CT scan. Having a CT scan will confirm your diagnosis and making sure. So this is a concha bullosa bilaterally, but here, once the concha bullosa extends up all the way up to the skull base, this is called an interlamellar cell. Okay, so it's different from the concha bullosa. And why this is important? Because if you want to remove this, you have to be very careful, because this is going and attaching all the way up to the skull base. So you don't want to twist it and remove it. You have to be very sharp and use sharp cutting instruments while doing this. Either scissors or tool. Never twist, never pull, never turn, never pull out aggressively. Okay? It's very, very important to realize, because if you don't understand it very well, you can have CSF leak just from removing a concha bullosa. It has been reported as seen. Folded and slit. Then, if we go deeper into an axial cut in this area, there are two structures or two areas we can identify. One is the Hiatus Semilunaris inferioris, which is the free edge cut between the uncinate process and the ethmoid bulla, which is right here. This is called the Hiatus Semilunaris inferioris. Then another thing we have is the Hiatus Semilunaris superioris, which is the area between the uncinate process, the ethmoid bulla, and the middle turbinate, right in this area here. So this is called the Hiatus Semilunaris superioris. So again, the inferior Hiatus Semilunaris inferioris is the shortest distance between the free posterior edge of the uncinate process and the anterior face of the ethmoid bulla, while the superioris is the crescent shape between the ethmoid bulla and the middle turbinate. And you can see it here. This is the uncinate process, this is the ethmoid bulla, so this will be the Hiatus Semilunaris inferioris. And then again, this is the ethmoid bulla, this is the middle turbinate. Here will become the Hiatus Semilunaris superioris. Okay, all this is by using a 0-degree endoscope. Having a 70-degree scope is sometimes very important in finding the natural ostium as opposed to a fontanelle, and this cannot be seen unless you use the 70-degree scope. So going into practical points, the first thing you want to do is when you want to start on the paranasal sinus surgery is having the scope, decongesting the nose, having a great view, and then gently, 3 times saying it, retracting the middle turbinate, medially to expose the ethmoid bulla. And you can use a freer by this, and you can use it very gently to avoid cracking the middle turbinate while doing this. And by doing that, you can see different variation of anatomy. Doing the maxillary antrostomy has been described in many ways. I use the backbiter, and I take about 1 or 2 or 3 bites. A lot of paranasal sinus surgery is by feel, so you have to really appreciate the feel of the uncinate process opposed to the lateral one. Once you start to getting into hard bone, and you can feel this now as a practical, then you stop at that point. And then you can expose the middle, the antrostomy very well. After doing that, you go into the ethmoid bulla. I like doing it by the spoon curette, and I like you to practice this as well, going into the ethmoid bulla with the spoon curette, inferior and medially, opening the ethmoid bulla, and then after doing that, you use sharp cutting instruments, especially on the lamina, which is on the lamina papricia. Once you get into that spot, the lamina papricia is of vital importance. You don't want to get into the orbit. And sometimes you find violation and you can have complications. And sometimes we find that the lamina papricia is right in the middle and you can avoid. Sometimes it's going laterally away from you, and sometimes it comes into your field. For that, we have done a study, Dr. Islam, myself, and Dr. Ahmed Sheikh, he's now in India, about a new classification of the lamina papricia accordingly to where it is sitting into that view. Is it medially, going right in front of you that you can get into a complication? Is it right in the midline? Or if it's laterally, and if it is lateral, you can simply miss opening some air cells and going inside. Especially in cases of allergic fungal sinus. You can avoid missing and removing some of the fungus, and after surgery you find still you had some cells lying on top of the lamina papricia, and that can eventually develop into complications. So this paper, after reviewing more than 200 CT scans, developed a new classification, Harzallah classification of the lamina papricia, type A, type 1 and type 2 and type 3, and type 1 is if it's lying less than 2 millimeters away from the part of the middle antrostomy, and then type 2 if it's medial, and type 3 if it's lateral. And here's are the examples. This is when it's lying medial, and this is something you have to be alert. You can easily get into the lamina papricia and having complication. And then type 3 is when it's lateral and it's away from you. And in this case, you have to dig a little bit more in that lamina papricia to get these fungal balls out or get the sinusitis out. So I find this very important. We can explain it more while we go through. The ethmoid bone, I'm not going to go too much about it, has been talked about a lot. Infraorbital ethmoid cells, we have to recognize it because it obstructs the middle meatal antrostomy, and you have to open it completely to have a good opening to the maxillary sinus. So this is an Haller cell, the large one here. See how much it obstructs the maxillary sinus. And again, another Haller cell here. You can see clearly. And then a very large Haller cell here and here. And this is kind of a very large Haller cell, and was given to me by Dr. Amin Jafar for approval. The infundibulum, it's a funnel-shaped, bounded by the uncinate process, lamina papricia, and it drains the maxillary sinus, the frontal sinus, and the anterior ethmoid. So this is the ethmoid infundibulum, which is very critical to recognize and know. Osteometal complex has been talking about before by Professor Rida. I'm not going to go too much deep into it, but the sinus lateralis is important. It's about the suprabulbar recess and the retrobulbar recess. Sinus lateralis, again, suprabulbar recess is between the roof of the ethmoid and the skull base. Retrobulbar is the one behind. And here you can enter the spoon curette and lift the ethmoid bulla anterior. So again, this is the suprabulbar recess with all the anatomy. Superiorly will be the skull base, medially the middle turbinate, laterally the lamina papricia, posterior is the basal lamina. Time is up, thank you. Just last point about the retropolar recess behind the bulla itself. We can see this while we are doing the endoscopic anatomy. Thank you very much.
I think now we can take a 10-minute coffee break till Professor Casiano start dealing with in the lab with the cadaver for the dissection demonstration.